Jinko. I'm okay. Greetings. You guys can see me. Why?
We can't see you, but we could hear you quite well. And I think he just dropped out. All right, let's just give him a few more minutes. Ah, there he is.
Wait. Okay. Sorry, I don't know what happened just now. Greetings to everyone joining us from around the world. It's wonderful to see such diversity in this virtual space today. I'm Dr. Himanat, and I'll be the chairperson for the section today. For the presentation, I would like to remind all the presenters again that this presentation is a 15 minutes presentation, but I strongly encourage everybody to reserve 5 minutes for question and answer. I also will like to apologize beforehand if I wrongly pronounce anybody's name, because maybe I'm not used to the foreign names and all. So without further ado, I would like to invite our first presenter, Ozge Esra.
Hi.
Did I pronounce?
Can I start?
Yeah, sure. Right.
Okay. Firstly, dear academicians and colleagues, welcome to all of you. I am also very happy to be with you, and I will start my presentation with screen sharing. I hope you can see it now. Okay, let's start. I will present to you the research of my master's thesis in clinical psychology, examining the effect of the mindfulness and act-based romantic relationship skills individual strengthening program on university students' mindfulness levels, emotion regulation, and relationship decision-making skills. A human being is a social entity that sustains its existence by forming relationships throughout life and fulfilling its needs. Romantic relationships also hold an important place in individual life. There are studies that reveal the effect of mindfulness and acceptance-based intervention on romantic relationships in terms of increasing relationship satisfaction, improving intimacy, commitment, and harmony, managing conflict with positive communication methods, and reducing verbal aggression. Supporting these skills when individuals do not have any romantic relationship can affect their experiences in the future. It can help them to cope with difficult situations in relationships more easily, recognize and regulate their emotions, and choose their behavior with awareness. It also seems that having mindful sex is effective in solving sexual function problems. Exploring one's own body with awareness by touching can prevent sexual problems. Additionally, recognizing relationship decisions and warning signs, keeping distance from thoughts, and taking actions while being aware of values can prevent potential problems in future relationships. The purpose of this research is to develop the mindfulness and act-based romantic relationship skills individual strengthening program and to investigate how the program affects the mindfulness levels, emotion regulation, and relationship decision-making skills of the university students. The program aims to improve individuals' decision-making skills in relationships, enhance their mindfulness skills, and reduce emotional regulation difficulties. These skills will strengthen individuals for maintaining healthy romantic relationships in the future. These experiences may prove useful for sustaining relationships through conscious decisions. And we invited participants according to these characteristics between the age of 18 and 25. university students, not have long-term mindfulness and meditation training, not have psychiatric diagnosis, have romantic relationship experience, not currently in a romantic relationship, and not experience a traumatic event in 6 months. We use some scales before research. Sampson checklist 90R we used, and the scale of body connection for pre-selection. The research sample consisted of 40 women who responded to online announcements and met the relevant criteria. The participants were given detailed information about the study. In addition, their questions were answered through an online individual preliminary interview. Now, you can see the demographic characteristics of the group in the table. Participants were randomly assigned to the experimental and control groups. The experimental group consisted of 20 people. 20 people also were included in control group. Participants who were absent from the session for more than 2, we excluded. The number of people in the experimental group who completed the study was filled out the scales was 14. In the control group, 14 people answered all the scales and their data were examined in research too. The research was conducted as a quantitative through experimental research design and was carried out using the pre-test, post-test control group model. The results were obtained by analyzing the pre-test conducted before the 8-session program and the post-test administered at the end of the program. We used these scales in the research: 5-phase mindfulness questionnaire, difficulties in emotion regulation scale, interpersonal mindfulness scale, relationship deciding scale, and also the irrational romantic relationship beliefs inventory were used in the one session regarding thought awareness. Responses to this scale weren't collected, and we didn't use it in research. It was only describing thought and awareness in the session. Now you can see the sessions here. 8-session mindfulness program we used was completed in 4 weeks and 2 sessions per week. Session 1, mindfulness and romantic relationships. Session 2 is about sensations and emotions. 3, understanding the mind and decision making in relationships. Session 4, mindful communication and thoughts. We talked about diffusion in this section. And the 5th one, acceptance and compassion. Also creative hopelessness we talked about in this session. Finding your way in love values, the name of 6th session. And also we talked about committed action in this session. Mindful sex and contextual self is the other session. And the last one, establishing a relationship with life. Each session has done nearly 2 hours and 50 minutes on Zoom platform. The program has supported with home exercises and either recordings. Now, you can see the results of pre-test and post-test results of experimental group. The research demonstrated that the mindfulness and act-based romantic relationship skills individual training program brings about a significant change in mindfulness, emotional regulation, and relationship decision making in the experimental group. You can see the results here and here. When pre-test and post-test in the experimental group were examined, the change in some sub-dimensions couldn't be detected as significant, but the increase in the mindfulness scores of the experimental group and decrease in the difficulties in emotion regulation scores in the sub-dimensions are noticeable. You can see these scores here. It is surprising that interpersonal mindfulness didn't change with a significant level in pre-test and post-test comparison of the experimental group. You can see here, this outcome may be related to the limitations of the research. And the other table, the pre-test and post-test comparison of the experimental and control group, significant results were seen in more subscales. You can see these results when you look at the table. The change in some subscale scores, which wasn't found to be significant in both groups.
Miss Esra, 2 minutes left.
Okay, it's finishing. Thank you very much. May indicate a significant difference in pre-test and post-test comparison of the experimental and control groups. This may be relevant to the limitations of the research and external factors. The results supported by literature that mindfulness and acceptance-based interventions are effective on mindfulness and emotion regulation. It is seen that this program also produces scientifically significant change in this area. In addition, the program supported relationship deciding in all dimensions. To sum up, there are programs in the literature that support mindfulness-based romantic relationship skills. However, there is limited content that combines ACT and mindfulness for individuals. In addition to this theoretical background, this program addresses issues such as relationship decisions, warning signs, conflict resolution, communication, mindful sex, and dating. At this point, we believe that working with a larger group to observe the effects of the program can produce clearer results. Additionally, we suggest that many personal and social processes may have influenced individuals' emotional regulation and mindfulness skills, such as reopening of students' schools, the transition from the family home to the school environment, exposure to the war through media in the Middle East during the experimental period. This suggests that it may be useful to examine the long-term effects of the program and conduct research with more participants. We are also curious about the impact of implementing to this program once a week. On the other hand, we aim to deliver the program face-to-face and assess its effects. Thank you for listening. If you have any question about details, you can also prefer to send email to me. This is my email address. I think it's okay. Thank you, Dr. Jimenez. I think it's true.
Thank you, Ms. Esra. It was a good presentation. I'll follow up with the floor. Any questions regarding her research? Maybe I'll start it with some what was the limitation from your research? Limitation that you found, the challenges that you found in your research. Thank you.
I think we can talk about the limits of participants because we studied with a few of people. I think 28 people is a really small group for this research, and we should observe the effects in a large group. Additionally, maybe the war can affect the people because of exposure to the war with media in Middle East. So it can be affect their emotion regulation and mindfulness skills. We can see that in control group. I can also show this if it's okay. We can see no differences in control group, pre-test and post-test, but maybe it's not significant, but some scores are rising and some ones are was decreasing. Maybe you can see here difficulties in emotion regulation increasing here, but it's not significant. But it can be possible to affected by the war, I think. And the other I talked about in my presentation, maybe it's school time, their opening season. I can say these, I think. I don't know it's enough for your question.
Yeah. I have a question. Would you consider that the mindfulness intervention here being used as formal or informal, or is it a hybrid or mix? Because as we know, formal and informal have very different domains that can be targeted, and it seems like some of your domains will not reach in terms of the results. So I'm just wondering, in your mindfulness intervention, would that as formal, informal, or just a mixture?
Okay, I can show this page to you if you want. This is about program. These are our exercises we used in the 8th session. Body scan, mindful movements, mindful walking, mindful drinking. Also in MBCT exercises like sounds and thoughts meditation or self-compassion exercise, loving kindness meditation like this. These are formal exercises. And we use some act metaphors like pen metaphor, falling in love, with Russ Harris also, hence as taught creative hopelessness, quicksand metaphor. And these ones are the need for literature we use in our research and our program. Maybe you can see in the other programs in the future.
So that was exactly why, this is why I'm asking actually, because yes, X mindfulness tends to be more of an informal kind of mindfulness practice, but I'm seeing a lot of different varieties of mindfulness practice here. If we look at it, your mindful movement, mindful walking, some of that could be what we consider as formal. It really depends on the script that's actually used. But this is where I would just want to comment that depending on what kind of mindfulness being used, formal or informal, they potentially could target different domains in a person's life. And that potentially could explain some of the data that you have discovered. Why is there no changes in emotional regulation, and so on and so forth? Sometimes it just if you emphasize a lot on formal, maybe it targets other domains that's not related to emotional, so on and so forth. But yeah, just a comment only. All right, thanks.
Okay, thank you very much.
Thank you very much. Maybe one more question, or if there's none, we can move on to the next section. Okay.
Okay, thank you very much for everyone to listen and ask questions and comments.
Thank you very much, Ms. Esra. We'll move on to the second presenter, which is Teng Yi Sun. You can take the floor. Thank you.
Hello, everyone. My name is Yishan. I'm actually a doctor working in the Department of Psychiatry and Psychological Health, Hospital University Malaysia Sabah. So just let me share my screen first. Right. Yep. So yeah, first of all, I would like to say thank you and grateful, especially to Prof. Dr. Nicholas Pang for giving me a chance to present this conference, and also to Prof. Walton Wider for guiding me in these studies. So my study is mainly to study the relationships between socioeconomic risk factors, psychological inflexibility, and depression among individuals living in rural areas. So as far as we know, over the past decade in Malaysia, prevalence of mental disorders has been dramatically increased according to the statistics of Ministry of Health in 2015. So, and then there is a recent rise in the suicidal attempts and psychiatric disorders within our society. So we had called for more vigilance efforts to determine the amount, the type, variety, and distributions of mental disorders in our increasing modernized environment. So there's some research gaps. The rural region of East Malaysia actually has the highest prevalence of mental disorders, which accounted 43% according to the national statistics in 2015. And so far, there's no conducted study in Sabah to correlate the social risk factors and prevalence of depression among native people who live in the rural communities. So before I move on, we have found that other papers have mentioned that greater psychological inflexibility has been consistently linked to increased stress, anxiety, depressions, and decreased well-being across a wide range of populations and conditions. So in my study, is to investigate the role of psychological inflexibility as a mediator relationship between the socioeconomic risk factors and depressions. And then it's mainly to see that if this psychological inflexibility can be a factor targeted as a mediator between the non-modifiable socio-economic risk factors and the psychological illnesses. So moving on, so we have collected data of 115 participants, the villagers who live in the rural area, northern part of the Sabah. The inclusion criteria in this study will be age at least 13 years old and above, having the ability to comprehend the questionnaires. The exclusion criteria will be under 13 years old or having any acute medical or psychiatric illness. Hence, this study is more of a healthy study populations. So we have actually 3 questionnaire as instruments to be used in this study. So we have socioeconomic risk factors, the PHQ-9 and the AAQ2. The socioeconomic risk factor consists of a demographic information such as gender, age, ethnicity, education level, marital status, employment status, house ownerships, car ownerships, and internet access. And for the PHQ-9, we are using it as a versatile tool for screening, diagnosing, monitoring, and assessing the severity of depressions. Lastly, the AAQ2 is a tool to assess the psychological inflexibility among the participants. So the period of data collections where we carry out the studies happens last year in 1st April until 31st September, which are about 6 months. And then the social demographic data was analyzed and described using descriptive statistics and also using the IBM SPSS. And then the statistical analysis of the median model was carried out using the PLS-SEM. And then lastly, an indirect effects analysis was performed on the structural model to explain the mediating effect of psychological inflexibility between socioeconomic factors and depressions. So let's move on to the results, where table 1 is showing the social demographic of total 115 participants, whereby I can see that 46.1% accounted for male, female is accounted for 53.9%, and the mean age in this group of 115 data collected is about 42 years old. And then the ethnic, they are almost equally divided. 48.7 are the native and the 51.3 are non-native. And then they were actually 77.4%. Most of them have actually received education more than high school. And then for the marital status, about 69.6%, more than half actually accounted. They are actually married. However, for the employment, actually about 50-50, they are not employed or employed. For the house ownerships, they were accounted 66.1%, they actually own a house. And for the car ownership, about 59.1% that accounted having a car. And then for the internet access, almost 83. A lot of majority, I would say, like accounted 83.5%, they have internet access in the rural community. All right, so we actually moving on to the measurement of the model assessments. So basically, 115 samples were used to assess the validity and reliability of the measurement and structural models. So the initial focus was on testing the reflective constructs of the psychological inflexibility and depression for their validity and reliabilities. So the table 2 actually shows a reflective constructs have achieved convergent validity and reliability. And then we move on to do a heterotrait and monotrait method to apply to determine the discriminant validity of the measures. So from the table 2, it has shown that all constructs using the HDMT value are less than 0.5, hence proving the evidence of discriminant validity of the measures. And then we move on to the structural model assessment. So as per table 3, the inner VIF values were all below 5, indicating there is no significant collinearity issues among the predictor constructs. Lastly, we are looking at the result of the structural model in the figure 1, in which it shows that the psychological inflexibility can act as a mediator in the relationship being the marital status and native and depressions. So this implies that being married is associated with a lower psychological inflexibility, in which leads to a lower level of depressions, And also our findings suggest that being a native ethnicity may be a protective factors against psychological flexibility, hence reduce the risk of depressions. So for the discussions, review that for the finding review that being married and being a native have an indirect effects on the depression via the psychological inflexibilities. Having someone to confide, share experiences with, receive support from can help individuals feel less isolated and alone, thereby decreasing their risk of developing depressions. And marriage can actually act as a buffer against psychological inflexibility, hence alleviate depression by offering emotional support, fostering resilience, and also social connections. So other studies have shown that marriage can provide a supportive and comforting environment, act as a buffer against psychological inflexibility. Having a spouse provide emotional support, comfort, and understanding allow individual to feel more secure and confident in their ability to navigate life obstacles. Process of navigating disagreements and overcoming obstacles within a marriage can help individuals develop greater flexibility and resilience in their thinking behavior, thereby decreasing their risk of depressions. Now we're looking at cultural identity and social support. Can explain that connection between nativity and psychological adaptabilities. First, cultural identity is essential to an individual's psychological health. Having a strong sense of belonging and cultural identity can contribute to psychological adaptability. A secure cultural identity enables an individuals to utilize their cultural values, beliefs, and practice to navigate life's challenges. And other studies have shown that Native people are more likely to have access to a social network within their communities. And these support networks can actually consist of family members and also cultural organizations or religions. This type of social support assists them in coping with stresses, developing problem-solving skills, and maintaining emotional equilibrium. Consequently, being a native, have a degree of psychological flexibility, which reduces the risk of depressions. However, in these studies, the education level doesn't provide as a protective factors against depression in studies. This can be departure from the norm attributed to the high prevalence of the poverty in the rural areas studied. As poverty and its associated stresses, such as limited access to the basic needs, such as medical, healthcare access, professional development opportunities, job opportunity mitigate education protective effects on the mental health. This can be justifiable from the statistics from the Malaysia 2020 highlighted the Sabah state, which I carried the study, has the highest rate of absolute poverty among all states of Malaysia. So the conclusion is that psychological inflexibilities can become a mediator for indirect effect between marriage, native ethnicity, and depressions. So in this study, marriage and native ethnicity are identified as a buffer and protective factors from psychological inflexibility and depressions. However, there's no mitigating effect of other socioeconomic risk factors such as gender, employment, education level for the psychological inflexibility and depressions. There's some certain limitation in these studies whereby, especially the ALIC2, which only primarily focus on experiential avoidance and cognitive fusions, which are only two aspects of the psychological inflexibilities, and we actually overlooking other crucial dimensions such as committed actions. In this study, I think the study sample size is actually quite small, and I feel that if we have able to have spent more time and to cover other districts of across Sabah, then we will have a better data collections, comparison between ethnic minorities to find out the risk factors precipitating to the depressions. Yeah. So here I conclude my presentation. Thank you very much.
Thank you, Dr. Dr. Singh. Okay, I would like to open up to the viewers for question and answer. Is there any question across the floor? Maybe I'll start up the question first. Doctor, how do you foresee the translation of your study to policy making or to reduce depression and so on? How do you foresee this study will be helpful for the community in the sense of public health. Thank you.
All right. Thank you, Dr. Hemanath. I think this is the first step as a study to open up a pathway to knowing that knowing that the factors precipitating to the depressions among the minorities, ethnicities in Sabah, because Sabah has a lot of ethnic minorities. I would say at least more than 5. So I think in future, how would I push forward to create awareness among Sabah is that I would need more resources to carry out a larger studies, so that I would use the data to publicize and use it to advocate the public, especially in Sabah, and also involve some publication with the Ministry of Health. Yeah, and then so that there might be some more funding from the Ministry of Health in order to have more psychiatry doctors and setting up more psychiatric facilities, accessibility for them. Yeah. Thank you.
Thank you, Doctor. Is there any question else from the floor? If there's none, maybe we can move on to the next presenter, which is me. Thank you, Dr. Sheng.
All right. Thank you, Dr. Hemanath. Thank you. Thank you, everyone.
Try sharing something, Suen, on your side. See, does it happen?
Yeah, just now I did it. It was fine. Yeah.
I saw you shared the translation slides, so there's no issues.
First of all, do you guys can see my slides?
That looks okay.
Yes, no problem. I'll start with my presentation. Greetings to everyone. I'm Dr. Hemanath, and I'll be presenting my research titled Cultivating Mindfulness Online, a Promising Approach for Smoking Cessation and Well-Being. The presentation of today content is from the introduction to the conclusion. Okay, we start up with introduction. As mentioned by WHO, the tobacco epidemic is one of the biggest public health issue being faced by the world currently, and it is one of the preventable leading cause of mortality and morbidity. Apart from that, nicotine content cigarette is also highly addictive. The nation has realized this, thus there has been a worldwide effort to help smokers to quit, but the smoking cessation achievement remains unsatisfactory. An article published on the United States Food and Drugs website also revealed that in a survey done in 2015, 70% of adult smokers wanted to quit smoking, but in the end, 55% attempt to do so, but only 7% were successful. As mentioned before, smoking is one of the leading cause of preventable mortality and morbidity worldwide. Furthermore, there is a big loss in healthcare expenditure secondary to smoking-related diseases, and topped off by productive loss as well. Other than that, current smoking cessation program also are underperforming. Okay, the justification for conducting this study is that mindfulness-based intervention has never been done in Malaysia to aid smokers in quitting. Furthermore, utilizing an online platform to conduct the intervention will be something new. Therefore, this will open new perspectives and possibilities in helping smokers quit smoking. Mindfulness therapy will be a great stepping stone for individuals to quit smoking and live a healthier life, because it encourages the participant to be focused on whatever task at hand. The general objective of this study is to determine the effectiveness of mindfulness therapy as a smoking cessation aid in Malaysia. Meanwhile, the specific objective is the specific objective has 3 and mainly compares the improvement of all the variables between smokers in both intervention group. The variables are Ferguson score, number of cigarettes smoked, and also QSU brief score. Okay, we move on to methodology. We used a randomized control trial study designed with a single blind. The study location was in Malaysia. The sample size was calculated using G Power Software 3.1, and the final sample size was 44 participants. Finally, the study we used was Google Form and Google Meet. Here are the inclusion and exclusion criteria. The inclusion criteria is adult age between 18 to 60 years old, moderately or highly dependent smokers, according to Vegastorm, able to understand Malay and English moderately. The exclusion is those who had undergone any other smoking cessation program in the past 3 months, on any kind of nicotine replacement therapy, including e-cigarette, currently using any kind of psychoactive medication, had a serious or unstable medical or mental condition. So participants were randomized in a group A, mindfulness, and group B, standardized behavior approach. Baseline values were ascertained through questionnaire before starting the intervention. 3 therapy sections were conducted for both groups with a 2-week gap between each section and a phone call each week as a reinforcement. Participants were required to answer a set of questionnaire 1 week and after third section and after 5 weeks. Results were analyzed using generalized estimating equation, GEE. Result, okay. This table shows analysis done for the categorical variable, mainly to prove that there was no difference between the two groups in the beginning. Abstinence rate at the end of the study is also included in the table, which shows no statistical difference between both groups. This group also, for the same reason, whereby it showed at the beginning of the study, there were no significant difference between the group for all the numerical variable. So from the chi-square analysis, before this, we can observe that even though the empty group demonstrated numerical superior in the abstinence outcome, the difference was not statistical significant. Another study which was done, 16-week study done in 2021, also recorded similar finding. This might be due to the short study duration. Hence, we continue to the study for longer duration, we might observe a better result. In this table, we can observe that there is a significant association between MT and SBA group across all the variables tested over time. The associated effect also lean toward the MT group according to this table. In this study, in this study, we are able to prove that the MT group was more effective in helping participants reduce the number of cigarettes smoked per day. The benefit of reducing the number of cigarettes smoked per day is it has a higher likelihood of successful in achieving smoking cessation. It is also linked to lower mortality rate, and it is proven in many studies that it can decrease the risk of developing lung cancer and respiratory diseases. Participants in mindfulness therapy group also showed a significant reduction in nicotine dependency, moving from moderate to low dependency. Ferguson score, as all we know, is a very useful predictor for smoking cessation success. Furthermore, quitting intention is significantly associated with quitting behavior for low nicotine dependency group compared to other groups. Individuals with low nicotine dependence level may be more responsive to smoking cessation interventions such as our mindfulness therapy. There was a significant reduction in QSU brief score among the MT group. Craving is a significant factor that can lead to relapse during smoking cessation attempt. Reduction in the level of urge to smoke through mindfulness therapy may help individuals manage craving and resist the urge to smoke, reducing the risk of relapse and increasing the likelihood of long-term smoking abstinence. So we move on to conclusion and recommendation. Although we are unable to prove the effectiveness of MT in smoking abstinence, MT are effective in reducing cigarette smoking, nicotine dependency, and managing smoking urges. The study's finding can advocate for policy changes and new training program for healthcare workers to increase the effectiveness of smoking cessation intervention. Incorporating mindfulness-based intervention in smoking cessation program could increase the chances of successful smoking abstinence outcome and reduce the risk of relapse. Further research is needed to explore the long-term effect of mindfulness-based intervention and smoking cessation outcome. My recommendation is training healthcare workers in mindfulness therapy can be more holistic approach to smoking cessation intervention. Utilizing online platform for quit smoking clinic can make the process more manageable for clients. Mindfulness therapy can be turned into mobile app to increase accessibility. Testing the effectiveness of mindfulness therapy alongside with pharmacotherapy can determine its viability as an alternative or adjunct therapy. Further research should aim to explore the mechanism underlying the effectiveness of mindfulness therapy in smoking cessation and determine the long-term effects. This is my reference, and thank you. Okay, thank you very much for all the listeners. Is there any question?
What's your mechanism of therapy?
Okay. Mechanism of therapy. What can you elaborate on that? Mechanism of therapy?
I want to say that exercise is useful for as an intervention for a particular condition. I would have to specify what kind of exercise, aerobic, anaerobic, why is it targeting that, why is it useful here. But in this case, what kind of meditation are you looking at? What kind of mindfulness are you looking at? And why would it help with cessation? Because you mentioned mindfulness therapy, but mindfulness therapy is as broad as me saying I'm using exercise to stop something. It has to have a baseline understanding. Without knowing that, we can't even know why you can't have much statistically significant abstinence and so on and so forth. 16 weeks is actually a very nice, it's a huge duration, it's a very long duration. So I'm just curious, when you say mindfulness therapy, what's the mechanism, what are you targeting?
Okay, mainly my target was on the nicotine dependency, the number of cigarette smoke, and also urge of smoking. Because according to researchers, these are the main culprits which will...
Those are the outcome, but which part of mindfulness are you using to target those things? Those are the outcomes.
Okay, from what I realized from my clients, the problems that they have in controlling the urge and craving and everything is mainly the denial. They deny nicotine is an addiction. They deny the journey of smoking cessation, whereby they don't they when there's a withdrawal sign, they think is not an illness. So by using this mindfulness, we how you say we make them realize that this the withdrawal symptom is a journey whereby they have to endure it, rather than they deny it and they go back to their smoking to overcome the problem. So they use this kind body scanning, they use quicksand, they use mindfulness walking. When they have the craving, they go for a mindfulness walk. When they're having the craving, they'll use the breathing technique, mindfulness breathing, to overcome the craving. And quicksand method. Yeah.
If I were to be brutally honest, I think more literature review and basic understanding of mindfulness will need to be more in depth, because you have a very good study here with a good duration. It's a good target. I mean, it's very useful. People are going to help. It's just that having a better understanding of the mechanism of mindfulness as a tool and how it actually can be directly utilized would help you shape your intervention much better.
Honestly speaking, I was the researcher, but then I was assisted by 5 other psychologists which were trained by mindfulness, which were supervised by Professor Nicholas Pang from University Malaysia Sabah. So I'm a public health physician actually. So I was mainly on research organization and also the analysis part. So I did not really interfere in their management in the mindfulness. I was more into the SBA because I'm a doctor. I was trained for using SBA according to our Malaysian CPG. The mindfulness, I did not disturb them so that it will not create bias in the study, because I'll be conducting the SBA. So we did there's two groups. One was conducted by the main was our Prof. Nicholas Pang from UMS, and I was conducting the group B, which is the SBA is mainly about the gold standard that we are using in Malaysia according to CPG 2016. So I know things from there, from whatever I read when I'm doing my thesis. So in terms of in-depth, I cannot explain it because it's not my core actually. I'm sorry about that. Thank you.
Thank you.
Just wondering, you had an active intervention on the other side. That's motivational interviewing based, isn't it? Is that right? Have I got it right?
What was that again?
The SDA, that's
Yes.
motivational interviewing based. Is that correct?
Yes. It's mainly according to CPG, according the standardized behavioral approach, the 5R, the 5-star, and so on. The one we usually use in our quit smoking clinics.
Okay, yeah. So we had 2 active interventions, didn't we? So it's quite hard to find a significant difference with that, I imagine.
Yes.
Yeah. Okay, and I think it was probably ACT-based if it's Nicholas doing it. I think that was probably the mechanism of intervention, I imagine, for the mindfulness program, I mean. So, okay. I think I'm taking over as host for a short while because Eugene's had to go for a second. Now, I've suddenly been asked to take over. I don't have the schedule in front of me. So who's the next person? Who's taking over next?
I think I'm gonna be next.
Okay.
Yes, I'm.
Is that Fadi? Sorry.
It's
Okay,
our
yeah.
turn, I think.
Okay. Sorry? Okay. So do you want to go ahead then, Fadi?
Okay, isn't it a bit early? It's fine.
Oh, okay. Have we got more time with the last one? I think.
Sorry, I think this time is our presentation.
Okay. Okay. Go for it, Norsina.
Next is share. Yes.
Okay. Sorry, but in my turn. What?
It's share's turn. Merveno is the last.
Yeah, can I ask a question? When will your chapter finish?
It's 10 minutes.
Another two presenters. The Share and Merveno.
Okay.
Okay, I will start the presentation. Is everything okay? I think.
Okay.
Can
You can go on first. Maybe Share will come the next. Okay. Thank you.
Hello, everyone. Firstly, let me introduce myself and my friend Nursena. We are both psychologists. So this is our topic. Sorry. We are both psychologists, and I'm studying at neuroscience. It's my master's degree, and today we're going to talk about the impact of high school students' goal, value, orientation levels on exam stress, and this is our our content will be like that as you see here. I will try to tell you our studies, purpose, and method chapters, and my friend Nursena will present results, discussions, and conclusion chapters. Our study is the impact of high school students' goal and value orientation levels on exam stress. And then why we did choose this topic? Because both of us work with acceptance and commitment therapy method. And the therapy method includes goals, values, goals, commitment, like that. So we just wonder these phenomena how impact on high school students' exam stress level. And then as we know, in Turkey, high school exam is a major milestone for students and their families. So we just want to try this research, our study. Our purpose includes, we aim to measure the relationship between goal, commitment, value orientations, and exam stress in a sample of 12 to 17-year-olds living in Turkey. There are many factors that affect exam stress. Besides, we know that behavior change depends on the value of the goal. Value point is an important side of acceptance and commitment therapy method. In this study, we wanted to combine these points of a goal, commitment, values, and exam stress. The method we used, the sample in this study consists of students from 20 provinces of Turkey. An online survey from consisting of a personal information form, goal commitment scale, West Coast test anxiety scale, and portrait value scale test was applied, and data analysis was evaluated using SPSS 27 statistical program, normal distribution analysis, correlation and linear multiple regressions tests, and significance levels. That's all my chapters. So my friend will be present the other chapters. Thank you.
Thank you, my vendor, and thank you all of you to present us. From this part, I'm going to continue. When we see the results, the study group consists of 101 people, 73 of whom are women, and 29 of whom are men, between the ages of 12 to 17. The average age of the sample in the 12 to 17 age group is 15.76. Research data shows the normal distribution. As a result of the correlation analysis, we found that exam stress is related to goal, power, success, and self-direction values. As we said, we see the same results from our correlation table. When we look at the exam stress from the last part, I did some circles to make it easy to understand. Exam stress is related with the power of value and goal and success of value and self-direction value. The dependent variable exam stress and the independent variables is goal commitment, and the power value scores were subjected to multiple regression analysis. The results appear to be significant. There is a negative relationship between the level of goal commitment and exam stress. There is a positive relationship between the level of strength value and exam stress. We can check from the tables from our analysis results. We see that our results are significant from analytical, and also we can say that goal and value of power, stress value have the negative relationship between each other, and their results also are significant. You can see from the circles. When we came to the discussion part, although 3 participants answered all questions of the survey, they were excluded from the data analysis because they answered no to the question, I approve of participating in the research. An outlier was identified, and when it was removed from the analysis, the number of relationships between measurements increased. The small number of participants in the study, the fact that adolescents are not aware of the importance of scientific research and do not answer the questions seriously may call into question the reliability of data. Maybe it may be a reason of we choose online answers the questions. And when we came to the conclusion part, this definition of Naylor and Ilgen, who explain their commitment as the problem solvers focus on the desire to sustain effort and achieve a difficult goal over time, supports our negative relationship between goal commitment and stress that we found our results. On the other hand, only one of the value commitments subdimensions was found to be related to exam stress, which it was a positive relationship between each other, and suggesting that the participants' general definitions of value types are not similar to each other. Adherence to the value of power can be interpreted as a student of growing power. It will be useful for educators and students, courts, to pay attention to this issue in future studies. It may be recommended to develop value skills for individuals in adolescence because we categorically measured value commitment. There is no, we couldn't find the scale that measures value commitment proportionality in adolescence. Thank you for attention and listening. And again, let's ask to present. Thank you.
Thank you very much, both of you. I will open to the floor to ask some questions to the presenters. Thank you.
Thank you. Then question.
Are you planning any intervention as well? Are you planning to intervene on it also at some point?
Yeah, I think we can discuss with Marvin for it.
Yeah.
Actually, we planned, but we didn't this so much hard because we were so much busy. We just tried to do this presentation or just the first registration. This is all fast. This was all so much fast, and we will try to do as you said, but we just think about that clearly. But if maybe you can say this worth it or not worth it. Maybe you can say about this research because this is our first presentation of this conference and like that. So we are so happy and like that and a little bit stressful, so you can
and also it's our first research.
Okay, yeah. It was really good. It's really, yeah, it's interesting findings, isn't it? Quite an important area. So yeah, it'd be nice to carry on, wouldn't it? You can't do everything at once, so yeah.
I would highly encourage it also because because even our two countries' similarity in terms of religion, being Muslim, Islam is actually one of the major ones. That same term, compassion, and when it intermixes with religion, it can has many meanings, and often we don't take that into consideration when we're dealing with our clients. What we might deem as compassion might not be seen as the same perception over our clients. Please do carry out and go deeper into this. This is a very interesting, I think, a much needed topic.
Okay,
Thank you.
thank you. This is so good. It's good to hear that.
Yeah, and it's so valuable. Thank you so much.
Okay, thank you very much. Maybe we can move on to the next presenter, Share.
Yes,
you.
I'm here. Just a moment. Can you see slides?
Yes, yes.
Okay. Hello everyone, I'm Seher, a clinical psychologist and researcher at Can Sağlığı Foundation. Today I'll be presenting in our research on the perception of compassion among Turkish people. Culture is defined as values, practices, and beliefs held by a specific group. It significantly shapes how we perceive and experience the world around us. One of the most significant examples illustrating emergence of cultural difference is the notion of compassion. According to Gilbert, compassion influenced by social context and roles entails a commitment to alleviating pain in both oneself and others. Perception of compassion can vary remarkably across cultures. This variance impacts the behaviors individuals consider social appropriate and their motivation to express compassion. These cultural nuances are pivotal, especially within therapeutic settings. The need for diverse approaches in therapy becomes evident when considering cultural disparities. These disparities significantly influence our understanding and expression of compassion. What is perceived as compassionate in one culture might differ elsewhere, highlighting the necessity for therapists to adapt their approach accordingly. Therefore, the objective of our study is to investigate attitudes towards compassion and related behavior in Turkish sample. By exploring these attitudes, we aim to gain insight into how culture shapes perception of compassion and how these insights can inform more effective therapeutic practices. When it comes to method, the 48 participants involved in research are from diverse across in Turkey, ranging in age from 18 to 56 years. We utilize 3K measuring tools. One of these demographic information form, and other tools is definition of compassion. That is, we gave the definition compassion as you see on screen, and ask people what it means, and it's like open-end response. And last tool is fear of compassion scale. This 35 item scale consists of and 3 factors that measure the fear of expressing compassion for others, responding to compassion from others, and expressing kindness and compassion toward yourself. Actually, that research is only exploratory research, so we use we look frequency and average were examined. As for the results, the answer the given definition are as follows. Among the participants, approximately 42% defines compassion as self-understanding, 29% as empathy, and 15% directly as compassion. Looking at the results of fear of compassion scale, the third item obtained the highest average score. Among the top 4 items, 3 were related to fear of expressing compassion towards others. These specific items are shown on the screen. As for the conclusions, participants mostly responded to the definition of compassion with answers such as being understand or and empathy. These are other qualities that compassion includes. There does not appear to be any problem in this sense. Maybe a suggestion in the therapy context, the word self-understanding or empathy may be used instead of compassion, depending on context of the person. And in Turkish demographics, there is a societal trend that frequently associated compassion with weakness or and vulnerability. Such perception might impede therapeutic outcomes when compassion is misunderstood. Moreover, item scoring highest, particularly in relation to expressing compassion to others, highlight specific areas requiring therapeutic attention. This underscores the therapist's necessity to create strategies that address these specific client concerns. And that's all, my reference. Thank you for being a part of my presentation. I hope we can embrace compassion for ourselves and others without fear. In these challenging times as the world, it's something to really needs.
Thank you very much. It was a good study. Is there any question from the floor?
That was really interesting, I think. I was wondering if, because you're looking at the way the culture interacts with compassion, is there other studies like cross-cultural looking at this?
Yes, it's a good idea, and maybe maybe we can further research.
Okay. It's not done already, as far as you know.
No, yes.
Okay.
Okay, thank you. Maybe we'll wrap up the presentation for today, because I think there's another presentation gonna be started soon. So thank you very much to all the presenters. Hope you guys will carry on your researches for betterment of our community. All right, thank you very much. Bye bye.
All right, thank you very much, everyone. Okay, so we move on very quickly to our next event. I'm going to pass over to the host, Dr. Marcus, who's going to Sorry, I called you doctor. But yeah, Max Marcus to kind of introduce the takeover as a host to work around with this. But I am very interested to hear about this because Fadi is going to present something from a region that we don't actually know a lot about. And I'm very much want to know what actually is going on within those areas. Over to you, Max Marcus, to take over, and welcome, Fadi.
Thank you. Thank you. Thank you very much, Eugene. Very good evening from Malaysia at least, and a very good day, good night, wherever you are. I am Dr. Max, and I'm from University Malaysia Sabah. I'm a lecturer. So I'll be chairing this session for Mr. Fadi Safwat. So I would like to thank the organizers and thank you all for being in this session with us. Without further ado, I would like to invite our speaker for this session, Mr. Fadi Safwat, who hails from Egypt, and he will be sharing with us his ACT group therapy experience for the Middle Eastern LAMIC countries. So for further introductions, I would think it should be better for Mr. Fadi Safwat to introduce himself, and the floor is yours.
Thank you. Thank you all. Thank you, Eugene, and thank you, everyone. It's a pleasure to be here. It's our first time as a nation or as a region to be in the LAMIC conference. So it's a great honor to be with you guys. Let me tell you about our region. We are the Middle East. I come from the Egypt, and we hold the ACBS Arabic-speaking affiliate, which include every Arabic-speaking country in the world. That include even people living abroad in Europe or the Americas. So as you can imagine, that's a lot of area to cover. We tried something different this year, and we like to discuss it with you guys. So I'm gonna share my screen. All right. Everyone can see it? All right, perfect. So I'm Dr. Fadi Safwat. I'm a psychiatrist from Egypt. And what we did is like we tried something new. First thing, I would like to ask a small question. Why do most of us love ACT? I would think that since this is an Islamic countries, ACT conference, that all of you use ACT in your work and your studies, and you do research on that. Why is ACT so special for you guys? If you can write on the comments, on the chats, that'd be nice. All right. Transdiagnostic, quick response. That is quite correct. Anybody else? For me, ACT answers lots of questions that other therapies cannot, like CBT or DBT. They address special other stuff also, but ACT is just like it works. It combines all different processes working inside of you, and it also gives hope. It gives meaning for you, especially in this world where everything is shaky, lots of things happening, lots of trauma everywhere. There's war that can happen or cannot happen. You always live on the edge in this world. So having finding the therapy that tells you that you can find meaning and you have values that guide you even when you don't have the energy or the emotions to go on, that makes amazing meaning for us, especially in the Arab region, especially that we have lots of wars going on in the region, like next by to us, like Egypt especially, is like we're surrounded by wars everywhere. So it's people here have lots of nightmares. People here have lots of anxiety of things that can come and what could happen next. So as I can see that ACT is more than a state of mind. It's not just talk. It actually changes you. Lots of research is done, and you guys did amazing studies before that prove that ACT really changes people. So it's a life changer. ACT really works. So the problem is we have a resource problem. As most of you guys are also LAMIC countries, resources are very limited. And speaking from the Egyptian point of view, psychiatrists and mental health professionals are really rare in our regions. We're talking about, I would say, like the regional, the WHO ratio should be 1.5 doctor for every 1,000 people. We have less than 0.8, and it's getting worse. Many of our doctors or many of our mental health professionals are traveling abroad, and that's a problem. So the question is like the $1 million question, $1 million question is how to help so many people who are really suffering and having meltdowns and PTSDs and anxieties and lots of other mental issues with little help, little people, limited resources and limited time and manpower. This reminds me of the trolley problem, if you are aware of it. So, you know, the trolley problem is a old philosophical question. Like if you standing like this and you find like this train, this trolley is gonna kill these 5 people unless you pull this lever. You're the guy standing there. So the trolley will go to another way. So in this way, you will save the lives of 5 people, but you'll have to kill 1. It's a sacrifice, and it's a big sacrifice to make. But as mental health professionals, as doctors, we do this all the time with the limited resources that you have. How are you going to help so many people with so limited time and also give them a quality care, not just anything? You want to give them something that really helps, that makes them happy, and that makes them healthy again, so they can live a more productive and a good life. So what we say is like, why not both? Why not offer help for many people as much as possible and also give them the quality care that they deserve? Okay, we don't have to compromise with your time or with your power when giving that. So that brings us to the idea of the group therapy. As far as we studied and researched, not many ACT group therapies exist. Like for sure, there are millions kinds of group therapies that exist, CBT, DBT, and many others, and they rely on the same principles invented or discovered by Irvin Yalom. If you know the guy, he says that the group therapy offers something unique and special. It's way more effective and gives faster results than the one-to-one experience that you have with your patient. Look, because when you go with the patient and you see him like weekly, sometimes it takes months. Even if you do the fast ACT, the fact, as Russ Harris says, it doesn't always give the exact good results, because sometimes there's dropouts, sometimes the patients are not feeling it. Sometimes on the therapist side, you find yourself preaching. You find yourself not using experiential service at all. You're just saying what you feel, and the patient is not responding or not receiving it. On the other hand, there's the group idea. So what's different about the group setting is that the people in the group help you. You're just not at the therapist or the leader of the group. You're not just doing everything on your own. Actually, every single individual attending the group is helping you, because people in the group help each other. They give feedback to each other. Like if someone felt something, he will help others to feel also. If someone has experienced, he will also help them. That helps people have a corrective experience, that other people are feeling what I feel. I'm not just the only single people in the school. There are many people also attending and feeling what I feel and having the same exact position. Although the circumstances may be quite different, but at the end, we are all humans. You all have the same kind of suffering, the human suffering, for different reasons. And as a group, as a family, as a unit, we have to go together. And using the imitative behavior that we imitate each other, and we support each other, and we make each other commit and do the commitment in the acceptance commitment therapy dance, so that we really commit to our values and our goals and do the homeworks together, that's what really clicks, and that's what makes ACT really effective. So this is the dilemma we found, that what we need to achieve is to offer an affordable option for our clients. We need to accommodate as many people as we can with the limited resources to really help them, and to be evidence-based and scientifically observed, and to be creative and let the people have fun with that and work together. Okay, this is not a school. This is not just teaching. It's experiential experience. You get to experience everything together as a group. You help each other, and this is where the magic happens. I don't think any research can really like quantitatively understand what happens. The group dynamics is very obscure. It happens like even without talking. The human experience really achieves something. Something clicks inside people and we change. But on the other hand, lots of research really support what happens. And you can really see the change that happened before and after. So what we did, this is my team. This is me, I'm Fadi. I had my co-leader, Nagla Eid. She's a licensed psychologist. And Hala, she is also an observer from Egypt. All of us were in Egypt. And we were tasked of doing this new thing. We had to create something out of nothing. We didn't have any resources on acting group therapy. And all of us had previous experience from DPT group therapies and other studies. So we needed to do something different. We need to do something to help people deal with the pain, deal with the emotional turmoil that people have, having no values and everything feels fuzzy sometimes, an existential crisis, for example, especially for people suffering from loss, from pain, from emotional pain, and different stuff. So this is the setting that we used. First, we decided that our group therapy is going to be on online therapy. It's going to be for 10 times, once each week, for 10 times. So it's like 2.5 months, which is amazing. It's a good time for people to bond and to get to know each other. And each time there was a new skill to learn. The group started usually was greeting each other, having a quick introduction every time, and doing special games. Then we revise the homework from the previous time, have a break, and then come to learn something good, something skillful, something that's going to help us achieve something different in our life. We aim that help people to be more flexible. This is what really makes ACT stand out from other therapies. That is our main idea, is flexibility. This is the main target. And to acquire a better care for each one, we decided each one of them of our team is going to be assigned to really notice 5 people. Like, we don't have to talk to them specifically, but each one of us will write notes about the 5 people that he's assigned to, and notice everything that he's doing. How is he speaking? Did he attend in time? Did he have a good response? Does he help each other? Does he care about himself? Is he going better? These notes really helped us to build the idea and the story about each one. And everyone felt noticed. Everyone felt accounted for. That's what makes a group really click. And there was weekly challenges and creative homeworks. Okay, our team is very creative. Like, we did everything as creative as possible. Our aim is just not give them the hard candy. We want them to really enjoy it. Something amazing, something new, not done before, and also very effective. We used lots of questionnaires before and after. We also used movies. We used weekly challenges, and we used to make them groups each time, so they get to know each other and confide with each other. And we made them to be one. We made them to really care of each other, the people attending, and with us. And something else that we as therapists, we also shared. We're not high and above everyone. We also share our secrets, our details, and we also want to be challenged and change every time. every time in every week there is something that we need to change, and we challenge each other. This week you're gonna do this challenge together and see how that goes. If someone falls, we help them, and we are therapists. We don't do that all the time. Sometimes people stand up for each other and help each other also, and that made them really click together. So we had a bit of a surprise. What is the target audience to do this? Well, we showed first, how about we do that for patients with anxiety or PTSD, or people who lost some people, but then it hit us with something amazing. Doing the research in our ACT peer supervision group, we noticed most of the people who want to learn ACT, and actually doing ACT, reading about ACT, didn't get trained on it experientially. They just read books about it. They don't have proper supervision. And the therapists in Egypt and the Arab countries, especially in the areas of conflict, they don't have someone to hear them. They get lots of burnouts. We don't have a burnout system for us. So we decided, how about we teach ACT for the people who want to learn ACT, for ACT practitioners, psychiatrists, psychologists, and everyone, and counselors in a group setting. So in this way, they get to feel the skills themselves before they apply it to anyone else. And in this group, you're not a doctor, you're not a priest, for example, you're not anything. You're just you. I'm Fadi. And each one of us shows a different nickname for them, so they become someone who they really are. They don't have to act as something other than themselves, being their true self, which is kind of in between to the self as context dilemma we have in ACT. And it worked out fine in this area. This is our group, and we have people from all over the Arab world. We have people from Syria, Palestine, Cyprus, and we have a Christian priest also attending, who happens to be a counselor. And all of us trained for 10 weeks together. So let's talk about the results. The group initially was 13. We had 3 dropouts, 1 early dropout, 2 late dropouts. And we did the PsychFlex questionnaire for the people before and after. And we noticed a significant increase in the flexibility of the people after attending the group. And also the honesty increased. Like people became more honest, less hiding behind the mask, if I might say. And people really changed. And to our surprise, people wanted to continue in this group after it finished. And we decided to make a peer supervision group specifically for those people who finished this group therapy and they want to do more. And we want to make more studies about that. We want to understand what really happened in this group setting. There's something magical happened, and we want to study it more. So the road ahead. What we want to do at the group setting is we want to study that more scientifically. So we want to do the same kind of group in different settings in Arabic-speaking countries and people, even refugees living abroad. So we are in the process of now making a research with the Cyprus University, with Maria Kaleka and her students, to try to study this scientifically with all the measurements and the data through a year on the Syrian refugees living there in Cyprus. And we want to cover the data and see what happened, what made that click, and how to make this accessible for more people all over the world with less cost. Our cost was so low, it was cheaper than going to regular settings. And it's even cheaper to try to learn ACT from other trainers. It's cheaper, and it was actually more profitable for everyone. So the thing is, especially in this economic crisis that everyone is having, how to provide better service, how to provide and help each other and learn and be supervised with less cost. This is what we're trying to do. And I would like to share about something with you, something that we're very proud about. We're doing our own conference in the Arabic speaking affiliate. This is the Arabic speaking international online conference. and it's gonna be amazing. We have Stephen Hayes, Russ Harris, Robin Weisler, and we have Nick Tornicki, and even the best of the best in the Arab world, people from different schools, from DBT and ACT and EMDR, and everyone. We're joining together in this Arabic-speaking affiliate conference and tackling different aspects of ACT. Like we have a group discussion about ACT and religion. How does different religions think about ACT? What's the difference between ACT versus EMDR versus DBT? How do each kind of therapy help people? And we also have a LAMIC group. We have Paulo here from the LAMIC help us also discover the different opportunities for LAMIC professionals they can get, and how to do the LAMIC for all and ACT for all project that the LAMIC committee is studying in the Arab world. We want more people, not just me, like the whole affiliate, to join and help and to learn and give more to the ACBS community. So you get to meet some of the best ACT experts in the world, and it's going to be on 1st and 2nd of December in 2 weeks' time, Friday and Saturday, and it's going to be translated, auto-translation. This is if you can use this QR code to get to the page. You can find it also on the ACBS website, in the Arabic speaking affiliate website. And at a special discount for you guys, get 10% if you use this promo code, something from us. Use this promo code ALIC, low income countries 10, and you go use this QR code and you get 10%. This is on us. And that will be all. Thank you, guys.
Thank you very much, Dr. Fadi, for that really, really insightful sharing. I would say it's quite interesting to actually hear something that is really, I would say, really positively impacts people who really need them. And as we all know, the current status of the region in where you're living is quite really need, the people there really need a lot of support, and it's really good to know that you guys are really making the effort to do so. So I would like to open the floor to all our listeners here for any questions. I'm sure that there's a lot of things that you'd like to ask our presenter here.
Fadi, it's rather interesting because less than 2 hours ago, while Claudette Foley was talking about SH+, we have someone by the name of Daphne Moroni who was talking about what she was doing in Cyprus. Are you aware of her work?
Actually, I helped Daphne translate her PsychFlex from English to Arabic, and she used that with the refugees, and also used the same psychometry in my group for the Arabic people. And that's why ED Rocks, like people from all over the world share their knowledge and help each other. And that's why we do something better together than going each on its own.
I find it very interesting the way we kind of connected all our events today. Each individual talk seems to be linked to each other unintentionally, but I do have one question to you. You mentioned about how your small group kind of get together and have discussions and have meetings and learn from each other on a regular basis. One of the things, at least within the Asian countries, that we tend to suffer is that we cannot find the motivation to get people to continuously remain in this kind of discussions. We will have very strong fire, motivated for 1 month. The second month, half will turn up. The third month, we'll be lucky if we have 2 or 3. We've tried this many times within Malaysia. Never had luck. How do you keep that? How do you keep that motivation high and among your group?
Like I was just studying the MRC Psych. I'm a psychiatrist, so this exam I'm studying, and one of the questions the MCQ said, what makes any group of people stick together or not stick together? the major cause of people dropping out or leaving a group or not doing what they want is but the ambiguity of the roles. Like people in your affiliate or chapter, what are they doing? Why do they matter? Are they just attendees? Are they people? Are they there just to help you, or to listen to the discussions, or to actually share? We made committees, different committees with different aspects. We have membership committees assigned to help people from each country. Like I have a committee in Syria, Lebanon, Iraq, Saudi Arabia, Egypt, of course, and Algeria, to attract members from these areas to our group. We have an peer supervision committee. We have scientific meetings committee, and we have social media and post committee. So since everyone has something to do and provide and also get recognition for the work he does, he feels appreciated and he comes more and he gives more. That's why we grew together. So it was never a one-man show. It has to be all of us together. That's why I'm really proud of all the speakers we have. We have 22 people, aside from the 4 keynote speakers that I told you about, Nick and Russ and Steven and Robin. Most of them people are Arabic. And this is amazing. This is the first time for them to reach the international and community and to provide and to hear and get heard also. That's what makes us amazing. I'm very proud of our work together. And also I'm very proud of the LAMIC work. You guys do really amazing work for us. And we use the resources that you provide, everything that was provided from the LAMIC portal and the ACBS website really help people. And when people find something as good as that provided for them, they get the tendency like, we want to do more. They did this and they like translated this to Arabic. How about we translate even more books, even more movies, and even more presentations to Arabic also for other Arabic users. And this is how we grow as a group, as a community.
Thank you. Thank you.
Thank you, Eugene, for that question. Well, I probably would like to add something to that. Maybe because, I do feel like the people, or rather the community in well, let's do it locally in Malaysia, they're not really susceptible, I would say, to this kind of interventions, because we don't have like generally our atmosphere doesn't really, we don't have something in our immediate surroundings that actually propels us to need this kind of thing. But probably those people that are in the Arabic countries, they needed some sort of distraction, if I may say so. So this comes back to another question that I would like to pose to Dr. Fadi. So what are the motivations of the subjects, or rather the clients that you have had in your group, for them to actually join? I mean, how would you recruit them? What would you say to them, actually? Yeah.
What, the group therapy or the ACBS community in the Arab world?
Your first intervention, where you had your team and each of you guys had 5 clients and you guys had all these kind of meetings. So what was the main goal, and what is the main motivation for them to stay through? Because sometimes, like, whenever you do have a job, but like when you provide and you participate, there's one point that you would say, I'm doing this repetitively. Where's the end point? Like that is actually what's happening in probably in my country, in Malaysia. So yeah, probably you can comment that from your side of the world. Yeah.
Well, from my side of the world, like many people hear about ACT, okay, and they want to know, what does it do? How does it really work? And the thing is, we don't have actually ACT trainers in Arabic. So what I offered, since I do ACT trainings on the side, like, how about instead of just doing ACT as boring, or just like using the models as a school curriculum, if I might say, how about to do it in an experiential way? many people that I taught before, they attended the courses of the ACT and they do it and they use the matrices or use the workshops and the papers and everything, and they didn't get the results before. And the thing is, when in the peer supervision, like we do a bi-weekly supervision for 3 years now in the Arabic community, we notice many people that use ACT are very dry in it, and they're using it without, you know, metaphors, and they are not psychologically flexible to begin with to help other people to be psychologically flexible. You see the problem here? So what we offered, how about the training program in a group therapy for you to learn ACT, really learn ACT, and so you try it on yourself as a practitioner to become more flexible and to really understand the skills on yourself and on your life before you get to ask it from your patients. If you are a really good ACT trainer, and try to act on yourself, you'll be a really good ACT trainer and practitioner. This is the philosophy, and many people are really interested and attend our groups to get better. And we want to try that on different settings also. So if any members also want to try that, our system, we will be happy to comply and do some kind of partnership to help to study this ACT and do it also scientifically with the whole matrices and do the whole psychometrics and before and after. And maybe you can write a paper together about that also. So this is how people get attracted. They want to learn ACT and they discover the real ACT in the process in a good period. 2.5 months is a good period for you to really understand and feel ACT and live it on yourself.
Yeah, I do really think that, you know, for the trainer to be able to really deliver a very good training or sharing, so the trainer must have had a positive experience with ACT. So technically, he's able to walk the walk and talk the talk. Yes, so do we have any more questions? We still have around 14 minutes for this session. Oh, yes. Jia Mei Wu raised her hand. The screen, the mic
Hi,
is
Dr.
yours.
Fadi. Thank
Hello.
you. Hi, Dr. Fadi. Thank you so much for that presentation. I think it's very encouraging to hear that, you know, how ACT is being translated in the, you know, in your country. And I personally experienced the challenges in trying to culturally adapt, you know, ACT in my country, especially when it comes to translating English to the Malay language in Malaysia. So I was just wondering, you know, in your experience, do you face any difficulties in terms of culturally adapting terminologies or the ACT concepts into Arabic or in, you know, in your local community? And how do you overcome that unique challenge that you face?
Okay, that's a great question, Jaya. I'm sorry if I pronounced it wrong, but when I first tried to translate PsychFlex that Daphne sent me last year, I had a team just to try to translate in a correct Arabic words, because if you try to translate it, I would say like in a dry translation, something a Google Translate would do, the results are really funny. Like, oh my God, it turns to curse words. Like,
Yeah,
oh my God,
that
what did you say?
happens.
Yes, and especially like what's it called? The one that Harris uses, the one with the needles, I guess. Hooked and unhooked. Hooked. Oh my God, I'll leave that for your imagination. And it's horrible. So my team and I spent enough time to translate it. And what we want in our Arabic community now, we are also after our international conference that we'll have in 1st and 2nd December. Our next step, we're going to do something even greater. We're thinking of making all the Arabic people from all the different dialects and cultures come together, and we would like to agree on the exact words that we'll need to translate the ACT metaphors and ACT words into our culture, ACT words that works with us, something that agreed upon by all the experts in this in a symposium. Everyone will be heard, and we'd also do something like a a poll, so we get census approval for each word, something that really translate to us in our culture. Also in our conference, we have a small talk also about the different culture context of each country and act. Maybe the metaphors that work for us in Arabic countries.
Right.
That maybe the metaphor what we created for just for Arabic countries.
That's great. Yeah, I see the alignment because I think that's something that the team in Malaysia, the Malaysian chapter, is also actively working on as well, to standardize the language, to standardize to make it more localized and to make it more culturally adapted for the local context, and be able to translate that in our therapy as well, making it more relatable to the people that we're working with. So thank you so much, Dr. Fadi, and really, really very encouraging, and really all the best for your chapter, and hoping that we are able to work together to make this a collaborative one, that our chapter can is able to benefit from just sharing knowledge and the procedures together as well. So thank you.
This is our the QR code will give us the will take you to the chapter, our Facebook chapter Facebook page, so you can contact with us at any time if anyone wants anything also. Thank you, and good luck with translation. Like I really rooting.
Thank you so much.
Thank you. Wendy?
It looks like you've been really successful at getting engagement and disseminating and just getting people working together really well. And like what you said about just giving people responsibilities and all that kind of stuff, it seems like really sensible stuff. So from the point of view of Developing Nations Committee, what do you think we need to be doing to kind of to sort of bring in other people and to get the whole community working together better? So I think this is probably a start, but what do you think we need to be doing next?
Since I think all of us are in the committee together,
Yeah,
we have the same problem. But I would say you have to start from the bottom up, like hear the people. Ask each community on its own, what do you guys, what will make you more engaged? What will make you practice ACT more in a successful manner? We found that what we needed more is getting more ACT material and having a vision by professionals and having Arabic speaking trainers. And this is what we're talking with the ACBS now, and we're getting the roles going to get more trainers and get more engagement, and get also this the conference that we're doing. It's something for us to hear other people's opinions and points of view from abroad, and also share our opinions together in your community. It doesn't have to be everything from outside.
Yeah. Yes, I think that's helpful. You're having in your in the Arabic speaking nations, do you have many peer review trainers, or are you trying to develop that at the moment?
I'm in the process to be the first one in the Arabic.
Yeah. I think it's the same in a lot of countries, isn't it? That was struggling. I think we don't have any either in Malaysia, and it's like ACT in Malaysia is really active, but we don't have peer review trainers. And so that's another issue, isn't it, that we need to sort out, which I think Paolo's trying to do with the ACT for All project.
Yes, I would support ACT for All project wholeheartedly.
Yeah.
Actually, like clap for you guys for what you're doing. What you're doing is helping, and it leaves a mark, and you creating a legacy. Really, every small step that we do together, it works out. It helps someone that you don't even know that existed. So
yes, I hope so. I hope so. Yeah.
Right.
So thank you, Dr. Wendy, for that question, and also Mei Wu. So now we are at 8:53. I think we have time for probably a last question to be entertained. I get it that this topic is rather hot, and there's actually a lot of rooms for improvement and ways to implement it. So yeah. Well, if there's no one's going to ask anything, I just would like to ask, like, from a, well, I'm not based in an from a psychiatry nor a psychology. I'm actually working in emergency medicine, so we don't really have a lot of people coming. I mean, I personally wouldn't have a lot of experience doing contributing towards ACT, but I would just like to know, since Maywu did raise about cultural differences, and you did say also that when you were setting up the Arabian committee for the that you have said earlier, so you were saying something that would, I think, was sounding like you would like to ask opinions from different religious leaders regarding the ACT usage in, probably from a religious standpoint. I was just curious, what is it that is probably, that you're anticipating as far as religion is concerned? Because I thought that ACT is mostly about lifestyle changes and yeah, mostly about thinking. Yeah.
Yeah, sure. That's a fair point. Well, in the Middle East, I would say also other countries also, but we are really into religion, you could say. And religion plays a huge role in our lives. And for us, religion also, it conveys most of the truth or the skills that you learn from ACT is actually embedded in many other religions also. Even like I'm Christian and have many Muslims in the Arab world. We have very similar points of view in our religions, and that's why ACT works perfectly with our faith. And we also found, like, when we learned mindfulness and we learned more about other religions like Buddhism and Hinduism, it made me understand my religion even more, especially like the self as context and the part of the self and no self in other religions. It really helped me understand mindfulness, and also it made me understand how to practice Christianity in a better way. So that's what we're trying to convey, and see that ACT and religion are not contradictory. Actually, they are complementary. They work perfectly together to creating a better life and something to live for in your life.
Thank you for that explanation. I think that the phrase, it actually helps to be a better person. Like, if you're a Christian, it helps you to be a better Christian, better Muslim, because some people would probably be averse to it, because some people might get like an idea that it's actually meditating, and meditating is a very strong word probably for people who are very, very religious. Yeah, so they just don't want it to be, to have another god, as compared to something like that. So it's a very interesting thing that you've done there, Fadi, in your place, and it's something, at least for me, it's a very, very big eye opener, and I can see, a lot of good things that are going to happen in your region, and I really congratulate you guys for actually making it that far, and I think it's a very good idea for you to spearhead that and really make ACT something that is really worthwhile to be practiced, not only in Egypt and probably in the whole Middle Eastern region. Yeah. So congratulations to you and your team.
I really appreciate it, and I'm waiting for you guys also to make even better impact in your areas. Together as a whole world, we'll create an even better world for all of us. Thank you.
Well said, Dr. Fadi. So I think, ladies and gentlemen, I think we have reached the end of our session. I would like to thank all of you again for a very lively and engageful discussion. And once again, I'd like to thank the organizers for inviting me and allowing me to be the moderator for this session. Thank you again also to our wonderful speaker, Dr. Farid Safwat, all the way from Egypt. And I wish you all the best in your future endeavors.
Thank you.
All right. Thank you very much. And I think we'll jump into the next one. I don't actually even know where to start to introduce Wendy, because Wendy goes way back. The reason why I'm in ACT was because of her. Basically, our next speaker is going to be Wendy Shoesmith, and she's going to talk about something that she has started and established in Malaysia itself many years ago, and it's still ongoing right now. The main topic is training non-specialist healthcare staff in ACT-based approach